Good night to everybody. Tonight, I will talk to you about regenerative minimal invasive dentistry. So, if you have an enamel caries lesion, a dentin caries lesion, MIH or MIH and caries, it's so important to get good decisions. Okay, what kind of treatment I will do in these cases? Regular treatment using handpiece, drills, or minimally invasive dentistry. If your decision is minimal invasive dentistry, it's important that today minimal invasive dentistry say to you that if you have a caries lesion in enamel, no cavity or cavity enamel lesion, you don't need to remove the lesion because today you have different kinds of materials. For example, silver diamond fluoride, SDF. It's perfect for minimal invasive dentistry. You have another kind of materials like resin infiltration, but today you have bioactive biomaterials that are possible to regenerate these kinds of lesions. And if you have dental caries, dentin caries lesion, it's different. Minimal invasive dentistry says if you have a dentin caries lesion, it's important to do selective caries removal. What means that? Remove that infected dentin because it's a tissue that is rich in bacteria, is demineralized, and the collagen fibers are denatured. So it's important to remove this infected dentin because it's a necrotic tissue, a necrotic zone. And then you will find a second zone that is the affected dentin. The affected dentin is demineralized but rich in collagen fibers. It's important to do it a selective caries removal in these cases. So when you remove all the infected dentin and work at the affected dentin, you can choose a different kind of materials. For example, you can use SDF. Or another option today is use bioactive biomaterials. That it's possible to regenerate the affected dentin. And if you have cases of reversible pulpitis, you can use bioactive biomaterials. So this is today the minimal invasive dentistry, because today minimal invasive dentistry is not a provisional treatment, it's a definite treatment. So it's not only for kids, because in the past we think that minimal invasive dentistry was only for kids. No, today is for all your patients, kids, adults, all your patients. So minimal invasive dentistry, you have two options, SDF or regenerative minimal invasive dentistry. Okay, here are all the materials, all the bioactive biomaterials that helps to you to regenerate. For example, you have nanohydroxyapatite that it's possible to regenerate enamel caries lesions, especially white spots. And in the case of MIH, to work and give minerals to this opacity, nanohydroxyapatite will help to you. You have a second group of bioactive biomaterials. It's Curodont. Curodont is the self-assembling peptide that helps to you to regenerate white spots and it helps to you in the case of MIH. If you have caries lesions so close to the pulp, or if you have a reversible pulpitis, you can do it indirect or direct pulp cupping using a bioceramic. For example, you can use it biodentin, neopathy. It's perfect for regenerate. Bioceramics are perfect. And you have another group of materials, restorative materials. Today, I will talk especially about restorative materials. These materials helps to you to regenerate enamel caries lesion and to regenerate the affected dentin. So these bioactive restorative materials helps to you because inside one of the components of these materials is strontium ion. Strontium ion today works perfect because it's an ion that helps to you to regenerate enamel caries lesion and to regenerate the affected denting. Okay, so if you have these cases, it's the best option today, regenerative. Okay, forget the past. Forget the only stop the caries lesion or arrest caries lesion, because today it's possible to regenerate using bioactive biomaterials. Okay, to compare minimal invasive dentistry of the past and today, I want to show you the minimal invasive dentistry in the 80s, so you can compare. So last year, I was at the London Dental Exhibition and the DeLorean, and that's why I said, okay, with this DeLorean, I will tell to my doctors to go back to the past, okay, and compare the minimal invasive dentistry of today and the minimal invasive dentistry in the 80s. So in the 80s, if you have a white spot, okay, minimal invasive dentistry said fluoride varnish, okay, applied fluoride varnish. But what happens? After 1 month, after 2 months, after 1 year, you're still looking the white spot. Why? Because you are only arresting the caries lesion, only stop the progression of the caries lesion. In the 80s, arrest is the only kind of treatment for minimal invasive dentistry. Never thinking regenerate, because the materials of the 80s are not prepared for regenerate, only for arrest the caries lesions. In the 80s, if you have caries lesions, especially interproximal caries lesions, minimal invasive dentistry in the 80s said, okay, you can do it, no restorative cavity control. What means that? Okay, use a drill, a burr, and open the contact, the interproximal contact, and then you apply fluoride varnish and control. What are you doing? You are waiting that, of course, you lost the primary incisor and coming the permanent. You are not doing a definite treatment. You are only doing something provisional because you wanted coming the permanent teeth. The same happened with whole technique. Whole technique said to you, don't remove the carious deletion. No, not effective, not effective, you don't need to remove nothing. Only with a steel crown, you close well, you fill well this cavity. What is happening here? Of course, the progression continues. It's going to be slow progression, but it's continued a progression. You are waiting that you lose this molar and coming the permanent premolar. That is happening. But sometimes when you are waiting, the progression of the caries lesion continue, and then you have necrotic cases. So be careful when you choose the whole technique, because sometimes you have these kinds of problems. Okay, but in the 80s, at the same time that you have, okay, black protocol that said remove all the denting lesions, infected and effective, or the whole technique that say, okay, don't need to remove nothing, you have right now the philosophy of Dr. Fusayama. Dr. Fusayama said in the 80s that it's important the selective caries removal. Dr. Fusayama, okay, shows that in a dentin caries lesion, you have two zones, infective and effective dentin. Infective dentin, okay, is a zone rich in bacteria, demineralizate, and the collagen fibers are denatured. And the second zone is the effective dentin, that is demineralizate but rich in collagen fibers. Okay, it's important. Dr. Fusayama said it's important to remove all the infective dentin because it's a necrotic zone. And when you remove, you don't need to apply local anesthesia. It's not necessary because it's a necrotic zone. It's important to preserve intact the collagen fibers of the effective dentin. Dr. Fusayama was a revolutionary in that moment, and he said, in the effective dentin, it's possible to regenerate. But what happened in the 80s? The materials in the 80s, these are all the materials that used it in the 80s are not prepared for regenerative. It's only prepared for a stop to arrest the caries lesions. Okay, why? For example, the fluoride, especially the fluoride varnish. Fluoride ion alone never will help you to remineralize. Fluoride needs to find calcium and phosphate ions to form fluorapatite. Fluorapatite will remineralize, not fluoride. It's fluorapatite. Okay, but what happened, for example, in the affected dentin that is demineralized, and if you use a regular glass iomer with fluoride, the fluoride is impossible that will find calcium and phosphate ions. So if not find calcium and phosphate ions, it's impossible to form fluorapatite. That's why sometimes this kind of treatment work or not. Remember in the past the ART treatment, it means that remove with the spoon excavator and then use a regular glass iomer that have inside fluoride ions. But in these cases, it's not going to work. Remember, fluoride needs calcium and phosphate, and effective dentin is demineralized. Okay, another. If you have white spots, remember, in a white spot, it's important to know the different zones of the white spots. In the surface zone, only you lose, the mineral loss is only 5 to 10%. And the body of the lesion, the mineral loss is 80 to 50, okay? And the porosity in the surface zone is 5%, and the porosity in the body of the lesion it's 25%. So it's important to give minerals, not to the surface zone. It's important to give minerals to the body of the lesions. Find materials that give minerals to the body of the lesions. And the surface zone is like a crystal. If you lose minerals in the body of the lesions, you will lose the white spots. But if you give minerals to the body of the lesion, then you are not going to see any white spot in the surface zone. Okay, so it's important to find minerals, to find materials that give minerals to the body of the lesions. How is the depth of a white spot? 300 to 500 micrometers. So it's important to know that because the surface zone, okay, the depth of the surface zone is 30 to 50 micrometers, and the body of the lesion is 270, 450 micrometers. Okay, if I get the decision to use a fluoride varnish for a minimal invasive dentistry treatment in white spots, fluoride varnish are going to work only in the surface zone, not in the body of the lesion. That's why the white spot is still looking white or change to yellow-brown. Okay, and what happened in MIH? In MIH, that today is our big headache, because our patients are coming with these opacities, yellow-brown opacities, the molar porosity breakdown so fast, the kids with a lot of hypersensitivity. As if we want to do any restorative, example with the resin, the adhesive is the worst, okay? So in this case, if we took decisions to use minimal invasive dentistry of the 18th, it's not going to work, okay? And today you have more and more cases of MIH. The prevalence, the global prevalence, of MIH, it's more and more. It's around 40.2%. And especially in some countries are more prevalent than in others. For example, in Spain, the prevalence is 21.1. In the case of the United States, different states have more prevalence than others. For example, here you have more prevalence of MIH. If you are looking Texas, you have more prevalence of MIH, 34%. We compare, for example, today, the 2024, the prevalence in Spain. Why I compare with Spain? Because I am living in Spain, and so that's why I compare United States and Spain. In the case of Spain, today, the prevalence, the 2024, it's 28.63%. In Germany, the prevalence is 28%, and in UK, one city, Leeds, the prevalence is 40%. So you will check that the prevalence is more and more. And today, you will not only check MIH in permanent teeth, you are looking in primary teeth and call hypomineralization second primary molars. Okay, so you have here the second primary molars with MIH, looking here the opacities. But if we talk about MIH, it's important to know that MIH means that you have opacity in molars and incisors. If you don't have opacities, hypomineralization in first permanent molar, you can call MIH. So today, let's talk about hypomineralization, not MIH, hypomineralization. And the prevalence of hypomineralization in the world right now is 25.3%. And the prevalence of MIH is 50.5. But you are not only have cases of hypomineralizations in first permanent molar. You have, for example, in canine, in premolar, in primary teeth, incisors, molars. Look, all these cases. It's often you can look in your dental office. So today it's better that hypomineralization, because MIH, remember, it's important that you have this opacity in the first permanent molar. Okay, talk about prevention in MIH is impossible. Why? Because we don't know the etiology. It's impossible to talk about prevention. It's important to know and understand the etiology to have the best decisions in the treatment. It's important to know that you have 20 to 25% less of minerals if you compare with a sound enamel. About the microhardness. Microhardness of a sound enamel is 300 to 400 loops, and MIH microhardness is 69 loops. It's important to know that in MIH, in an opacity, you have especially a lot of proteins. All these proteins are not usually in enamel, are more usually that you can find in dentin. But if you find these proteins, the problem is that these proteins are inhibitors of the crystal, of the hydroxyapatite crystal growth. And if you, for example, want to etching these enamels, these hypomineralization enamel, instead to have a etching pattern type 1 to open the porosities, you will have an etching pattern type 3. What means that? That close the porosity, and that's why you have a lot of failures in your resin restorative treatment. Okay? So again, you will find hypomineralization is a porosity enamel that breaks down so fast. Look here. This is the opacity in 12 months breakdown. In 18 months, not only breakdown, it's breakdown and caries lesions. And it's impossible that you can tell to your patients to brush well the teeth. Why? Because these kids have a lot of hypersensitivity. Okay? So you have risk of caries lesions too. And if you take the decision of use fluoride varnish, for example, for these cases, it's not going to work. Fluoride varnish is not the material for doing a treatment of MIH. Look here. You apply the fluoride varnish, the protocol that applied each week for 4 weeks, and look here, after 18 months, break down. because it's not going to help to you to break down the hypomineralization, okay? Look here. Look these molars with this opacity, yellow-brown opacity. Today said, okay, use fluoride varnish or use the regular glass ionomer sealants. Okay, what happens? These kind of sealants are not going to prevent the breakdown of the enamel. It's going to, look here, it's going to break down the hypomineralization enamel. It's still the glass ionomer sealant, but not prevent, of course, the breakdown. So it's important to get good decisions when you are going to choose the materials to work in MIH. So we are going to forget the 80s because the 80s are 40 years ago, and in these 40 years, change our life. We don't still with the Motorola of the 80s, with this cell phone mobile. Today we have an iPhone and smartphones, okay? And we don't still listen to music with a cassette like the 80s. Today we listen to our favorite song with Spotify. And if we want to watch a movie, we are not going to rent a movie in Blockbuster. Okay, we go home, we turn on the TV, and we have Netflix. So in these 40 years, our life changed. Why we don't change our dental practice? It's important to change the knowledge. The knowledge is the power. So today, to work minimal invasive dentistry, that is the definite treatment for all your patients, kids and adults, it's important to know and understand this kind of materials, SDF and the regenerative materials, the bioactive biomaterials that helps to you to do a regenerative minimal invasive dentistry. Okay, bioactive biomaterials mimic the biomineralization that is different as remineralization. Remineralization is the interaction of ions. For example, interaction of fluoride, calcium, and sulfate is remineralization. But biomineralization is different. Biomineralization is the interaction of ions with organic matrix. The biomineralization is the same that happening with development, for example, enamel, dentin, bone, these tissues that are rich in minerals, okay, necessary are organic matrix, okay? In the case of enamel, the organic matrix is the protein called amelogenin, and in dentin, the organic matrix is the collagen fibers. That's why it's important when you have a dentin caries lesion, do it all the selective caries removal to remove all the infected dentin and work in the affected dentin. And it's important to preserve intact the collagen fibers because the collagen fibers are the key to regenerative the affected dentin. Okay, you have a dentin caries lesion, you remove all the infected dentin, and look here, this is the looking of an affected dentin. This affected dentin is prepared for your bioactive biomaterial. In this case, I will choose Riva Light Cure HB. That is a glass ionomer modified with resin rich in strontium that will help to you to regenerate. Okay, let's check the X-rays. We compare. This is the caries lesion. Look here, perfect seal because we were working in affected dentin and this material are regenerate the affected dentin. That's why you are not going to look any radiolucity between the dentin and the restorative material. What happens if you leave infected dentin? If you leave infected dentin, you will check in the next rays. Look here, this is a restorative, a regular glass ionomer with only fluoride ion. And if you don't remove all the infected dentin and said, okay, I'm going only remove walls and not all the floors, okay, this is happening. Okay, look here, spherical, that is another bioactive biomaterial, and continue the progression of the caries lesion. This is infected dentin. Okay, so I remove all the infected dentin and I work in the affected dentin. Right now, look the color. That's why it's important. It's important to remove all the infected dentin and preserve the affected dentin. Ready, our affected dentin? We are so close to the pulp, so the decision is indirect pulp cupping with a bioceramic. Okay, I use the bioceramic and I can use a Rivalite Cure HD immediately. In the case of biodentin, I don't need to spend 12 minutes. With Rivalite Cure HD, you can do it, the restorative treatment immediately. Okay? Check the difference. This is the X-rays, no? Looking the radiolucity, that is caries lesions, and right now, no radiolucity. What means that? That you are working in infected dentin, so this is important because you remove all the infected dentin, and with your bioactive biomaterials, you are going to regenerate these affected caries lesions. Okay, when you work with bioactive biomaterials, it's important to have organic matrix. In the case of enamel, the organic matrix are the amelogenins, and in the case of dentin, the organic matrix are the collagen fibers. Okay, we are ready right now to talk about these bioactive biomaterials. So today, I will talk about restorative bioactive biomaterials, rich in strontium. These kind of materials are going to help you to regenerate because the strontium, if you look the strontium in the periodic table, look here. Okay, this is calcium, this is the strontium. So strontium is an ion that right now it's playing a great role to regenerate enamel caries lesions, to regenerate dentin caries lesions, and works perfect in MIH. The strontium ion you will find in the pink Himalaya soil and in the Brazilian nuts, and in your restorative materials plays an important role because interaction forming the strontium appetite. Okay, if you have restorative materials rich in strontium, you will help to regenerate the caries lesions, MIH. It's important because the strontium inside these materials will help to you to control hypersensitivity, okay? And remember, for example, the glass ionomers, that inside is inside the fluoride ion. If you have a strontium and fluoride, both ions can interaction and form the strontium fluorapatite. So today, the fluoride is not going to need to find calcium and phosphate ions. It's going to interaction with the strontium and form the strontium fluorapatite. That is better than only fluorapatite. And when you do this interaction fluoride strontium, it's more potential, okay, to be more antibacterial. So it's not going to adhesive the biofilm around these restorative treatments. Okay, which materials are rich in strontium? Which material helps to you to regenerate? Okay, let's talk about glass ionomers. These glass ionomers are rich in strontium. All Riva, for example, if you want to use a glass ionomer sealant, you have Riva Protect that will help to you to regenerate. Look here, this case, these molars with these opacities is MIH. I use in this case Riva Protect. This case is a long follow-up for years, okay, perfect, working this glass ionomer sealant. 5 years late, everything worked well, but after 5 years, of course, a glass ionomer sealant is a provisional treatment that helps to you for prevention. Okay, but in this case, I want to show you that look here, it's not the yellow-brown opacity. The strontium inside the Riva Protect helps to give minerals to MIH enamel, okay? You have restorative glass ionomers like Riva Self-Cure or maybe Riva Light Cure that is a glass ionomer modified with resin. Both products are perfect for cavities class 1 in enamel. Works great. But if you want maybe do treatments in cavities class 2 or cavities indenting a deep caries lesion, it's better if you use high viscosity glass ionomers. You have Self-Cure that works similar, for example, like IKEA, that is different if you work with Riva Light Cure HD. Riva Light Cure HD is unique because it's a unique glass, high viscosity glass ionomer modified with resin. So helps to you because in the case of Self-Cure, the setting time is so fast, okay? In this case, you have 10 minutes to work. So it's great for kids because you can finish one cavity and you can have time to do the next cavity. But not only helps to you for the setting time, it helps to you because Riva Light Cure HB is one of the materials that have more concentration of strontium. In this study, shows to you that when you compare 3 different kinds of glass ionomers, Catapult molar, not strontium inside, IKEA, that is only 7% of strontium, and Riva Light Cure HB, that have 50% of strontium inside, only the Riva Light Cure HB, after 28 days, you will find the strontium in the affected dentin, starting the regenerative of the affected dentin. Okay, in this case, you can use it in adults and resist perfect occlusion forces. Look, this molar, after a root canal treatment, you can use Riva Light Cure HB. Look here, the follow-up is 6 years. Works perfect. Okay, and in MIH is the best alternative. Use this glass ionomer modified with resin, high viscosity. You only need to remove the infected dentin because in this case is MIH and caries. You remove all the infected dentin and then you work direct in this affected dentin with Riva Light Cure HB. Look, everything works perfect. But what about the composites? It's possible to find composites bioactive? Let's check. Composites are aesthetic, are perfect, okay? If you compare, of course, with an amalgam, okay, the aesthetic of the resins are great. But sometimes you have problems with your resins. You have a lot of failures in your composites. Why? Because composites are like plastics. Plastics that need to adhesive in an organic matrix, for example, collagen fibers. So when you use a resin, you need to prepare the dentin, making a hybrid layer. To make a higher layer, it's important if you decide to use a etch and resin adhesive or decide to use a self-etching adhesive. The difference is if you use the etch and rinse adhesive, you are using the orthophosphoric acid and you remove all the smear layer. What happens? You expose the tubules and your patients, it's possible that have hypersensitivity post the treatment. Okay, but if you use the self-etching, okay, you are not going to have problems of hypersensitivity, but you are not going to have a good adhesive. That's why today are using the universal adhesive, that you can use it like a rinse and like an etch and rinse adhesive or like a self. But still, we're still with the problem of the hybrid layer. The thickness of the higher layer, it's so important to have good results in your treatment. Another problem with the composites, with the resins, you need light. So you have contractions, no, of this material. If you want the best aesthetic, you need to buy different sharings, different colors to have the perfect matching color in your treatment. Another problem with the resins, it's not going to resist so well the occlusion forces And you need to polish so well. It's important to polish well because the rugosity of this material then coming the biofilm and it gives us there the bacteria. Okay, if we think in an ideal composite, okay, and give me all your wishes that you want in a composite, thinking that I am like the genius of the lamp that will help to you to make an ideal resin. Okay, give me all the properties that you want to have an ideal resin. Okay. If you give me, okay, all your wishes, of course, you will tell me, Rocio, I want a resin that I don't need isolate. Okay, I want a resin that, for example, I don't need light. A resin with wall fill. A resin that I only need one color. It's only one shade. And it's going to be chameleonic and mimic the color of the enamel and the dentin. If you want a resin that be bioactive, if you want a resin that helps you no sensitivity post-treatment, today you have the future of the composite. Today you have Stella. Stella is the master of regeneration. Why? Because inside Stella you will find strontium ion, calcium ion, and fluoride. That's why today Stella is the new bioactive resin and helps you to regenerate enamel carious lesions and dentin carious lesions. You have two presentations of Stella, Stella capsules and Stella automix. It's coming showing. Okay? If we want to compare a similar material as Stella, we maybe can compare with SDR Flow Plus. But SDR Flow Plus, that inside is a strontium too, is still working with the hybrid layer because needs to prepare using prime and bond, prime and adhesive. Okay, in the case of Stella, we are going to forget the hybrid layer because Stella is not going to work with adhesive. Stella doesn't need to use adhesive. Okay, this is Stella. You have a Stella capsule, a Stella Shireen. The difference, it's not only the presentation. The difference is that Stella Automix is more flowable than Stella capsule, and Stella Automix gives to you 1.5 minutes to work, and Stella capsule less. The setting time is more fast. And the failure content, okay, in Stella Automix is not only a strontium ion, that is the best bioactive ion. You will find another bioactive ions like barium and boron. Okay, this is the difference of Stella Automix and Stella capsules. Okay, with this Stella inside is strontium and fluoride, of course, it's important because it's not going to have any problem with the biofilm adhesive around this restorative material. And the color, remember, you only need one shade, and that's it, because Stella is chameleonic. Okay, check this paper, Dr. Logercio, after 6 months, so that no change the color of a Stella Shireen or Stella capsule after 6 months follow-up. So Stella is a stronger restorative. It's so strong, like an amalgam, resists so well the occlusion forces. And look here, it's not working with the hybrid layer, it's working with integration. So the key here in Stella is a Stella primer. Stella primer is 10 MTT and have the technology MEC, methyl ethyl cetone. Why is important the MEC technology? Because if you forget to close well the bottle of a Stella primer, don't worry, it's not going to evaporate. Okay, look here, Stella primer It's like a water. That's why the penetration is perfect of a Stella primer. If we compare with a regular adhesive, the viscosity is more. Look here, okay? That's why sometimes don't have a good penetration of this adhesive. With the Stella primer, you forget to use adhesive, forget to use the orthophosphoric acid. But if you want to use it, it's possible because Stella, it works perfect with multiple techniques. For example, if you want to etch the enamel and dentin, then you can use a Stella primer so well. If you want to do a selective enamel etch only in enamel, then you can use a Stella primer and works great. And if you don't want to use etching, indenting, or enamel, a Stella primer will work perfect too. Okay, this is the difference. Stella works integration, gap-free, and with the regular resin that works with adhesives, okay, of course you need the hybrid layer and you have gap problems. Okay, Stella is flowable. It's flowable, so for cavities class 2 works perfect. The flowable resin works perfect in a cavities class 2 to have the best seal. So Stella indication for pediatric dentistry, it's great. For geriatric dentistry, it's great. For adults, it's great. So Stella is for all your patients. For cavities class 1, class 2, cavities class 3, class 5, for pediatrics, for everything, for every treatment. Okay, let's check in this case for a treatment for pediatric dentistry. This is a baby, 1 year and 11 months, and my decision. Look here, the x-rays. These caries are deep caries lesions, 1 millimeter close to the pulp. So it's possible to use a Stella. Works great in this case. So here I use the regular resin, and here I use a Stella. We're going to compare a Stella with the regular resin. Look here, this is the baby, and after 3 years follow-up, Stella works great, and not the same as the regular resin. We compare the x-rays. This is the x-rays after 3 years. Look, perfect sealing, no radiolucities between the restorative Stella and the dentin. Here, yes, look here, the radiolucity, not good sealing. Okay, that's why Stella helps to you to regenerate. If you check in an x-ray, Stella looks radiopathic. Okay, how works Stella? This is the protocol to use Stella. Okay, in the case that you decide to use Stella, auto-mix the shireen. Okay. You have a cavity indenting, you prepare your cavity, selective carious removal, remove all the infected dentin and works in effective dentin. It's ready, your cavity. So your first step is use Stella primer. You apply Stella primer and, okay, wait for 5 seconds. After 5 seconds, you can dry 2 to 3 seconds, okay? It's ready, and right now we are going to prepare our shireen. Okay, this is Stella shireen that it's important to prepare. Look here, you open. You have here the base and the catalyst that will mix with this point, this auto-mix point that helps to have the perfect mix of Stella. Close well, and you are ready for Stella. Go to the cavity. Remember, Stella is bulk fill. Stella is bulk fill and limited. It's not the classic bulk fill that says 4 millimeters. Stella is unlimited. Okay? Ready? I will show to you some cases with a Stella. Look here. This is a molar with a dentin caries lesion. And after I did a selective caries removal, look here, this is the affected dentin. My cavity is ready for Stella. First step, remember, Stella primer, 5 seconds, and then 3 seconds dry and ready for Stella, okay? This is Stella Primer, Stella Automix. And in the first minute and a half that you have the time to work with Stella, you are going to look the change of the color. First, the color of Stella is more white, and then Stella is chameleonic, mimic the color of the dentin and the enamel. Okay, let's check the follow-up. After 6 months, works great. 24 months, works great. 3 years, follow-up. 3 years, look, perfect. And in this time, my patient decides to do a bleaching. And look here, Stella mimics the color of the bleaching after 3 years. So that is different with the rest of the resins. This is another case of a caries lesion indenting. Look here, 1 millimeter close to the pulp. In this case, it's an adult. Okay, selective caries removal, ready our cavity. First step, Stella Primer. Remember, leave 5 seconds, then dry 2 to 3 seconds, and ready for Stella Automix. In the case that you are using a matrix, wait 4 minutes to get out the matrix. Look here. The looking is perfect. After 3 years, works great. We compare with these other resins that the color change. With the Stella, no problem. This is a molar, a primary molar with a dentin caries lesions. Okay, in this case, selective caries removal. We have here the affective dentin. If you want to do a selective etching, it's possible with a Stella. You're doing a selective etching, then you apply Stella Primer, leave there for 5 seconds, then dry 2 to 3 seconds, and Stella Automix. Look, the color mimic after 1 minute and a half is mimic the color of Stella. So Stella works perfect for dentin caries lesions. Remember, Stella is the unlimited full fill. And Stella is so flowable that it's possible to use it in dentin and in enamel like affiliants. Look here. In this case, caries lesion in enamel. Today, minimal invasive dentistry said if you have an enamel caries lesion, you don't need to remove the lesion. Of course, for these cases, we need a material that can give minerals, that can regenerate it, but at the same time works like affiliant. And Stella, it's possible to work like affiliant. Okay, it's so flowable. So if you have this kind of enamel caries lesions, of course, you can do it an etching, rinse, dry, and then first step, Stella Primer, and second step, Stella Automix. Ready. The treatment is ready. So fast. Okay, this is another case, these molars with caries lesions. The same decision, use Stella for these cases. And Stella is so flowable. Look, it's a perfect fill. In the case, for example, of this kid, look, a supernumerary. This kid was so sad. He said, I don't want to go to the school. My friends all the time said, why my incisor looks like this. It's different as the rest of my incisors. So, okay, we decide to do it here, a pediatric strip crown with a Stella. And check here, perfect finish, perfect the looking. It's a perfect for aesthetic. Okay, the kid is so happy. And in MIH, Stella is the best material, is the best for MIH. Because remember, in MIH, when you have these molars, no, that right now are molars with the opacity but not break down, it's important to fill, but not with a regular filling, a glass iomer filling, because it's fluoride inside. It's important to decide to fill this fit and fissure with a material rich in strontium and be a definite treatment. Because sometimes when you took the decision of use, for example, this glass iomer sealant, what happens? You need to do so often recalls to your patients. It's usually that you need again, and you have the risk of breakdown the MIH enamel. Okay, so if you have these molars, look here, look the opacity, yellow-brown opacity. This color is a high risk to break down. So in this case, I decide to use Stella. Stella, because Stella will give a strontium to this MIH. This is so important. Look here. So first step, I deproteinase because in MIH, remember, the problem is the albumin protein. So I deproteinase with a papain enzyme that is BRIC 3000, 1 minute. You can use, for example, this brush like this. I will show you the video. 1 minute. And after 1 minute, we did the etching, 20 seconds. Rinse and dry. Stella primer. Remember, you will leave 5 seconds and then rinse and dry for 2 to 3 seconds. Okay, look here, Stella Automix. It's so easy to work. It's like a sealant. Okay, it's ready. Look here, perfect. And after 2 years, look, the kit is changing the teeth. Look, and right now, so after 2 years, look, Stella. Perfect. You don't need to recall and no risk to break down these MIH molars. Okay, this is another case of Stella. In this case, is MIH and break down the enamel. The same protocol. First step, deproteinase. Second step, etching. Third step is Stella primer. Fourth step is Stella. And look here, after 1 year, everything works great. Here, this hypomineralization in this molar, and of course, breakdown and dentin caries lesion. Okay, let's check. We remove the infective dentin and works in the effective dentin. Ready the collagen fibers. If I want to do selective etching, okay, I protect the affective dentin. I did the selective etching, and then I use Stella primer, then Stella Automix, and perfect. Look, the looking, the color, the matching of the color is perfect. And after 2 years, it's still great. You don't need to polish. That is the terrific of the Stella. Stella is terrific because you don't need to polish. It's perfect. Okay, let's check this premolar. This premolar is hypomineralization and breakdown. No caries, but breakdown. In this case, the same decision. First step, deproteinization. Second step, etching. Third step, Stella primer. And fourth step, Stella Automix. Okay, ready the treatment. Okay, I don't need to remove nothing. Remember, minimal invasive dentistry say if you have an enamel lesion, you don't need to remove. You need to choose the perfect material. And in this case, it's a Stella. Look here, 24-month follow-up, 2 years, works great, Stella. This is another case of a Stella. This MIH molar that continue all the time, break down the resin, problems with the resin, and of course, the caries progression, it's close. The caries right now is close to the pulp. In this case, I remove selective caries removal of the infected dentin. I use a bioceramic because it's an indirect pulp cupping. And if I want to do a restorative, okay, after a treatment with a bioceramic, in this case, I wait 4 weeks. After 4 weeks, I remove the bioceramic. I prepare with the 18 Stella primer and then Stella. doing injectable resin because Stella is possible to work like an injectable resin. And this is the looking after the treatment. Great looking with Stella. Remember, Stella mimics the colors. Okay, I want to show you and present to you the creators of Stella that makes this amazing product. You will love Stella because Stella is perfect for all your cases. With only one shireen, you can use it in enamel carious lesions, in dentin carious lesions, cavities class 1, cavity class 2, for primary molars, for permanent molars, in your geriatric patients, in cavities class 5, works perfect Stella. So Stella works great for minimal invasive dentistry. Remember that today the future is the regenerative minimal invasive dentistry. Forget the past, forget arrest caries lesions. Today it's important to regenerate. Thank you so much for your attention.
Okay, and now we are going to open it up to Q&A from the audience. So everyone, please type your questions in for the presenter. You can type those questions into the Q&A box if you haven't done so already. And then we are going to have Adrian from SCI is going to chime in and field some of these questions to Dr. Lazo for us.
Thank you, Lisa. So we've got a question here, Dr. Lazo. How do you know when you have removed the infected dentin and not the infected dentin and not the affected dentin? Just to clarify the question, I think, how does a clinician know when how much affected dentin they can leave behind? Yes.
Okay. It's not easy. It's not easy because, sometimes you said, oh, I don't know if I remove all the infected or if it's still the infected dentin. So it's important not only if you feel like a hard tissue, it's important the color. That's why if you, for example, use a tool like papain enzymal, example, Brick 3000, it helps to you because the gel change the color. If you work in infected dentin, the color is like the gel change color like a brown color. And when you are in defective dentin, this gel is not going to change the color. It's still in this in this green, light blue color. So helps to you. That's why is my suggest when you start doing selective caries removal. Then you will have the experience of the color. And then when you when you are going to do X-rays, in the X-rays you will check no radiolucity. If you don't check radiolucity, it's because you remove all the infected dentin and you work at defective dentin.
Terrific. Thank you so much. Okay, another question here. Can we use Stella in binding endo crowns or overlays?
Okay. In this case, Stella is not a cement, okay? It's possible to use Stella in post after root canal treatment. You can use in post, but not like a cement for crowns. No, it's not Stella for cement crowns. No.
Okay, perfect. A question here. Do you use caries detection dye?
No. If you want to do a regenerative selective caries removal, impossible to use it. Why? Because it's a chemical. It's chemical and will denature your collagen fibers. Remember, collagen fibers are so important to interaction with the strontium ion, calcium, phosphate ions, and regenerate. So never forget.
Okay. Another question here is asking the 3000 item that you use, the biometric IDPC material. I think it's the Papa Caries material that you have. There's a question about what is that material?
Okay. The Brick 3000 is the papain enzyma that is bioencapsulate. This is the difference with Papa Caries. Papa Caries is a papain that sometimes if you, for example, change the temperature or change the pH, they don't have the same potential to remove or to deproteinase. That's why Caries it works together with chloramine T. What is the problem with chloramine T? That if you have a deep caries lesion so close to the pulp, it's possible that can inflammate more this pulp and possible to necrotic. And in the case of MIH, the chloramine T makes sensitivity to your patients. That is the difference, because one is a encapsulate technology and the other is a regular papain. No, this is the difference.
Okay. So a follow-up question from the earlier question regarding infected and affected dentin. Based on the answer that you provided, the Brix 3000, does that change the color to brown if the infected dentin is removed? Is that correct?
Yes, exactly. Helps to you the color. The color of the gels helps to you to show you, okay, you're still infective or you are right now ineffective. Helps to you. When you start doing selective caries removal, helps to you a lot.
Perfect. If you are not removing any enamel on an occlusal restoration, how do you not alter the normal occlusion present before the treatment?
Okay, if I have, for example, enamel caries lesion, I don't need to remove nothing. I don't need to remove nothing, any preparation, nothing. You don't need to prepare nothing. Only the same steps like a sealant. You can use a Stella like a sealant. First step, etching, then Stella primer, and the third step, Stella automix. And it's so probable that when you tell to your patient, okay, I want to check the occlusion, the patient said, ready, perfect. You don't need then any check the occlusion, nothing.
So just to further clarify that question, there was a case there that you showed minimally invasive treatment with MIH, where you applied Stella on top of the MIH affected area. Do you ever have issues with occlusion in those situations, or are you only applying a very thin layer of the Stella material?
It's a thin layer. Stella, it's so smart. I want that you start using Stella, because Stella is a smart restorative material that immediately it's going to go inside, the pits and fissures, and it's not you're not going to have problems that, okay, then I need to maybe polish because the kids feel uncomfortable when close the mouth. No, any problem. So happy to be tonight with doing this webinar. I am in Spain, so for me it's morning, early morning. So have a good night to everybody.